Hey, you guys, let's get started. Thanks so much for coming, for spending your time with us. On behalf of Captain Scott Goldstein, welcome to the Pikesville Volunteer Fire Department Training Space. For those who I haven't met, my name is Shawn Brast. I am anesthesia and ICU physician at Hopkins. I'm a member here at Pikesville, and I have the honor of serving in the medical director's office as CAR 609. On behalf of Medical Director's Office, Dr. Sagal, who's also here at CAR 606, and the EMS Office, Director Shedding, Captain Willits, Captain Stewart, Captain Natz, thank you. Thanks for your support. And for the live stream, for our young people who are making this available to folks throughout the county and throughout the state, Ashley and Hunter, thank you so much. Today we have Shawn Brast. Shawn is a clinical education specialist for Gilchrist Hospice since 2018, retired from Johns Hopkins Medicine after 29 years in critical care transport. Shawn is a nationally registered paramedic, earned an associate's degree in nursing from Baltimore City College, Bachelors of Science from the University of Baltimore in Healthcare Administration, and a Master's of Nursing with a clinical concentration in nursing education and simulation from Morgan State University. Shawn and I worked together some 20 years ago.
No, it can't be that long.
It was, right?
Yeah, I guess you might be right.
It must have been, right? Because I graduated fellowship in 2000.
Yeah. Which doesn't fit my age. That's the only thing.
Nor your picture. Hey, thanks so much. Great to reconnect, and thanks for sharing your passion with us.
Thank you, sir.
For your time. Thank you.
I greatly appreciate everyone being here and taking time off to do this. I have quite a bit of content I'm really excited to be able to share with you guys. Ashley and Hunter had promised a bloopers clip at the end of this. So, right? Or maybe not. Okay. And moving on here, no disclaimers to share with you guys. If you do have an interest in my handouts, you can use your phone and scan up, and that'll bring up the handouts for you, or I'm happy also to send that out to people by email. Give you guys a second for that one. So objectives, one of the things I want to really focus on, and I think it's pretty relevant to this group, is why do hospice patients call for 911? And there's not a lot of research, so we're going to do our best to kind of sort some of these things out. I do want to share a little bit about Gilchrist, as well as kind of hospice overall, and then have some discussions about why is it we do some of the things that we do in hospice. Some of the medicines that we work with on the one hand are pretty familiar by name, but the concentrations and how we administer them is not. And so we'll kind of cover things as we go. Just out of curiosity, just a show of hands, who's been here longer than 10 years? Nice. Longer than 15? Longer than 20? Longer than 25? Longer than 30? My Lord. Longer than 40? Anyone here ever transported a patient in a Cadillac ambulance? I got one. Okay. Fantastic. The next thing I want to kind of get a scope of is, have you worked with a hospice patient in the last week? Show of hands. Okay. Last 3 months? Last 6 months? So pretty big degree of frequency that we see this. And then have you had a personal experience with hospice? Just kind of a show of hands? Yeah. And the personal experience of hospice will range. I had 3, and it was literally the good, the bad, and the indifferent. And so, hospice is this concept here that I want to explore a little bit more with you. But just a little bit of background. The concept of hospice as it stands here and now today is new. It was first kind of introduced to the United States in its modern version in the late 60s, early 70s. The earliest, probably some of the best documentation about hospice was during the Crusades. And so those who were in Europe would go down to the Middle East and fight, get sick, come back, and along the way, volunteers would take care of them. The modern founder of hospice, as we currently know it, is Dame Cicely Saunders. And so Dame is the recognition for knighthood for a woman. And she started out as a social worker, became a nurse, became a physician, and started the hospice movement in England, and then brought it over here in a pretty important lecture. And after that lecture, there was a lot of interest from a variety of different groups. Medicare and the government at that time figured, can we provide a better level of service, and can we also do this in a way that's cost efficient? And so by the late 80s, we came up with the hospice benefit, and there's been a couple reiterations of this over the course of time. In 1994 is when Gilchrist started, and it started as Hospice of the Baltimore at that time. And since that time, it's grown, and we'll share a little bit about that. So hospice is a bit of a challenge at times, even for us to wrap our heads around, because it's not a person, it's not a place, it's not a thing. It's this very non-tangible, more philosophic kind of approach. And so, what you want this last part of your life to look like, that's what this hospice thing ends up being. And which makes it, kind of interesting, because if you had 3 separate patients, and they had a similar diagnosis, and they had a similar upbringing, and they had similar experiences, you're going to see 3 widely different things for what this hospice thing looks like. Now, in the best context of what this is, for a large part of our existence is the curative model. We fall down, we hurt our arm, and we go to the doc, and we say, "Doc, when I do this, my arm hurts." The doctor says, "Don't do that," right? But at some point, the burden of illness is going to happen. And so, how many of your patients have 5, 6, 10, even more different comorbidities? And from that standpoint, that's when kind of a palliative approach starts reigning supreme. Because if you think about it, those that are with a heavy disease burden, so there's primary care, and kind of the primary care docs are even starting to specialize in some things. And there's a cardiologist involved, a pulmonologist involved, a renal doc, and the list goes on. How much coordination really happens? And this is one aspect that palliative care can do. Now, palliative care is more traditionally in a more of a facility type setting. And so many hospitals now have a palliative service, and then we transition to hospice. And so hospice, this can be in a home situation, this can be in a residential care setting, which we refer to instead of the term facilities. So this could be any assisted living, skilled nursing, long-term care, any variation of that. And then ultimately, death. Now, bereavement is something that can happen before, during, and after. And so bereavement can be one of the first contacts that patients and families may have. A perfect example of this would be using bereavement counselors for children of patients that are on service. Now, there's a big shift. I'm not sure you guys have noticed. The silver tsunami, you heard this one? And so what's going to be happening in the next 20, 30 years? So those that are older than 65 are going to outnumber those less than 5. There's going to be a huge shift in demographics. Much of the spending really for Medicare recipients happens in the last 2 years of life. And roughly a third of that is in the final year of life. And so if what you're seeing now in volumes it clearly is an older population, look out, here it comes, because it's going to get even more progressive with that. Which really begs the most fundamental of all questions. Who's going to take care of me? And I think that's a pretty legit concern for all of us to be thinking about later on. So a little bit about Gilcrest. Gilcrest, there are roughly 5,000 plus hospices within the United States. Gilchrist is the 37th largest when you look at daily census. Our daily census now is closer to 1,000. We onboard about 400 to 500 patients a month, and then we have roughly 300 to 400 patients that will die in a month's time. Now, the challenge with this is about a third of the patients that come on to service with us are going to pass away in the first week. And so all the services that we wrap around, all the benefit that we get, all the outcomes that we strive for, that looks very different when you're on hospice for a day or a week, as opposed to 6 months or longer. We are closer to 800 staff members. We have about 600 volunteers now. We do have 3 inpatient centers, GBMC. I'm pretty confident you guys are aware of. Anyone familiar with the Joseph Ritchie House down in Baltimore? That's now Gilchrist Center, Baltimore. And we are about to break ground any day for a new inpatient. And then our other inpatient center is out in Howard County off of Cedar Lane behind Harmony Hall. So as far as inpatient beds, we use them for symptom management. We use them more so focused on that aspect of care. We have 34 beds that are at behind GBMC in Towson. We have 22 beds that are at Baltimore. Now there's 22 beds, 4 of them are for pediatric patients, and our pediatric census is somewhere around 50 or so patients. We are currently the only hospice that does pediatric patients in Maryland. We also have a carve-out for residential patients. So if you're in a situation to where you need assisted living plus hospice care, and you're living on limited funds, you can potentially come and stay in our location, and we have a sliding scale that we do for that. Probably one of the things that really speaks to me about the mission, vision, and values of the things that we do is if you qualify for hospice and you want hospice, doesn't matter, you're getting hospice. We turn absolutely nobody away. We're very fortunate in the fact that we're really well funded, and we're able to provide millions of dollars per year to support patients and their families that don't have the funds for kind of traditional inpatient stays and traditional care. So the thing that's really changing about hospice and what's really kind of changed about Gilchrist is it's becoming much more of a palliative type approach in the home care and the inpatient center, and a much broader scope of care. So we have our elder medical care practice. Instead of taking a patient from home to the doctor, we bring the provider to the patient at home. And it's a case management approach there, and so there's quite a bit of work that'll happen with a case manager, a social worker, and then there are some other individuals that will help with, if there's a challenge with electricity being turned off or needing other support or other care providers. Our home care is probably what most people kind of think about for patients, but a trend that is relatively new for us is until the last couple years, the biggest piece of our volume was home care patients, and now that's becoming patients that are in residential care settings and facilities. And this is something that's following the trend nationally as well. Care Choices is a really cool concept, and Care Choices is a demonstration program that Medicare is doing. And what they're doing is they're taking a select population of patients and they're matching them with a hospice as well as curative care. So they're getting both their curative care as well as their hospice care in this demonstration project. And what we're literally looking at today is probably in the next 10 to 20 years, this thing of what we see as hospice now is going to dramatically change. So there may be a much more of a greater latitude for this palliative care approach and this curative approach that we're seeing across the board. When we poll people, and I'm willing to bet that if I asked you guys the same question, where do you want to spend the last days? You want to spend the last days in a skilled facility of some sort, or do you want to spend the last days someplace else, at home? And most people, about 90% of people, depends whose numbers you like on this, say they want to spend their last days at home. What ends up happening, though, is about 75% of patients actually end up dying in some sort of a healthcare facility. So whether that's a hospital or skilled nursing or long-term, about 75% of patients will end up dying in a healthcare facility. When we look at kind of hospice, nationally, about 60% of people end up dying at home. And again, these numbers are shifting. The numbers I have here are about 10 years old. About 30% actually die in a hospice facility, like the ones I mentioned for Towson or Baltimore or Howard County. And then there are palliative care centers in many of the hospitals now, and they may die in an acute care setting. Now, one of the things that is kind of interesting, and if you pick up any journal about hospice or palliative care, roughly about 40% of them, and since this article was published, was who lives longer, patients on hospice or patients not on hospice. What do you guys think? So we've got to be careful about the literature, is the lesson here. And so the article indicates that those that are on hospice live longer, and by some estimates up to like 90 days longer, which really doesn't kind of pass the test. But when you look at it a little bit more concretely about the research article, one of which is it's retrospective data. Two, it was published by two actuarians, so they're not even like healthcare people, they're actuarians. They looked at a database from Medicare. The database from Medicare, there's some challenges. When you look at codes for illnesses, you could have 50 different codes for one thing of cancer and 49 different variances of what that looks like, and so that gets to be kind of challenging. And then, the other thing is you need to kind of look at, well, who published the article, who supported the article. And it was the National Palliative Care Group that supported that article, which I think is good for reading, but the better data that comes out of this data set is that patients that are on hospice probably don't necessarily live longer, but they do have better quality. They do have better symptom management, and we do see better outcomes with patients and families. When we think about what outcomes could be, so obviously there's patients, and we want to make sure that their comfort is well managed. When we think about families, what does that outcome look like? And so, that outcome looks like everyone's going to experience this thing again. It's going to happen. It's unavoidable. And so if you come away with a better set of skills after having experienced this, next time when this happens, you'll be in a better situation. So, here's a little bit more details about this bit of research there. But, again, you have to kind of be careful what you read in the literature. When we look at hospice patients in the United States, the last set of numbers I was able to get was around 2015, so that's 1 million. As I mentioned, about a third will die 1 week on service, and we're seeing about 30 to 33% of our patients. So we're pretty much aligned with that. About 50% will die in 2 weeks, and then 10% will stay on service with us longer than 180 days. We have some pediatric patients that have been with us, and they'll live on service with us even for a couple of years. We even had one who came off service, came back onto service. And so it's not uncommon to have graduation, is what it's referred to. The interesting thing about graduation is the couple that I've been directly involved with, it doesn't have the happy undertone as one thinks. Chances are you've had a really rocky course to get to hospice. You've really made some really challenging and difficult decisions to get on the hospice. And you kind of reconciled yourself to things and start preparing for things. And lo and behold, the medical care while you're on hospice is dramatically increased. You could have a nurse come visit you 3-4 times, even 7 days a week. You could have a hospice aide with you 7 days a week. You could have a chaplain who's there on a weekly basis and even twice a week. You could have a social worker that's there. There could be volunteers that could be there. And so the intensity of care for many patients that are on service with us increases. Now, another variation that you guys will be kind of the early experience to is revocations, and then discharges are a little bit separate. But revocation is when somebody wants to say, I don't want the hospice benefit anymore. And so the way that this whole hospice benefit works is when you're at a need for hospice and a healthcare provider identifies that, he or she will then make contact with a second healthcare provider. They'll collaborate and they'll say, if nothing changes in the disease state as it stands here and now today, in the next 6 months, we would expect somebody to pass away from that. And that 6-month window tends to be a pretty reliable for prognostics. And so the way that the hospice benefit happens from there is this most unimpressive piece of paper. It's a 1-page piece of paper that 2 providers sign. It has to be a physician or a DO. And it says that they would expect that, if nothing changes, you're going to pass away in 6 months. When the hospice benefit starts, it starts out for the first 90 days and then a recertification, and then the next 90 days and a recertification. And then after that, it's indefinite, but it's every 60 days. And at every 60 days, there's going to be a face-to-face. And so most of the time, it's nurse practitioners that go see patients in their home to get them recertified or if they don't recertify. The care, as we focus on things, is all about comfort. It's all about symptom management. And so our approach is very different from when you think about the curative care. You know, the reliance on having blood assays and urine cultures and things aren't always required. You know, surgery is typically not something that we're going to expect someone who's getting hospice to qualify for. But when you look at the money that's associated with this, Medicare, if you're living in the home for a routine level of care, or you can be living in a residential setting, it's about $190 a day. If you're in the inpatient setting, it's just shy of $800 a day, which if you kind of think about that you know, doesn't account, especially when we wrap the services around, you know, your medicines are provided for, the soft goods for the medical equipment, the durable goods, you know, walkers, porta potties, canes, so forth are provided for. And so, you know, it makes the budgeting thing kind of a challenging thing. So that's kind of the overall general gist of hospice. Does anyone have any questions so far? Yes, ma'am.
I didn't know that there were hospice patients in nursing facilities. Mm-hmm. How do you identify them?
So ideally, when the care providers are there, they're going to tell you it's a hospice patient. Having witnessed many transfers, that doesn't always happen so well. On their chart, they tend to have a flag, and then, you know, they'll have a MOLST in hand, but there tends to be a flag in their chart. And ideally, someone tells you that it's a hospice patient. And usually, if you're seeing a DNR, there's probably at least a good 60% chance that it's a hospice patient. But I've seen some situations to where it's not clearly communicated. You know, with respect to our colleagues caring for patients in residential care settings, you guys as a group are just a little bit intimidating at times. And so they may not be always kind of forthcoming with that information. Any other questions about what I've covered so far? Yes, sir.
You mentioned the growing trend of a combined hospice plus curative care center. What does that look like?
So right now, for this demonstration project, which has probably about another year, rumor has that they're going to extend this. But patients with HIV, COPD, congestive heart failure, and cancer and there's a bunch of other requirements that are required that you have to satisfy for this. And so they get their curative treatment at the same time they're getting their hospice care. What we are hearing from the national organizations is this is what hospice is probably going to be looking like in 10 to 20 years. So I'm sure there's probably going to be some more research that's going to be done prospectively, but this could be a huge shift, and everyone's kind of thinking that this is probably going to happen. Any other questions so far? Did I give you anything that didn't sound right? Okay. So I'm going to shift gears, and the next thing I wish to provide for you guys is a tool. And the tool is to be able to, how to kind of size up things when you're working with patients that are on hospice, as well as when you're working with families. You know, kind of the standard approach from EMS, we get there and there's some sort of a crisis, and you know, we expect to see a normal set of patterns with that that's compatible to any other patient population. But there is a little bit of difference, and this may even work in other situations. But I kind of have 3 buckets, if you will, that we can have patients and families in. And for that matter, we can even kind of fit into this bucket. So this first bucket is the warrior. The warrior is an individual who has very strong beliefs about what they want for end of life, may deny the need for hospice or fight it or challenge it. They may have 30 medicines. As another, something a little bit more concrete when you're looking at somebody who's 90 years old and has 30 different medications. They are resistant to care. They may not want to go to the hospital, or they may want everything kind of done at the hospital. If you kind of think about what I'm describing here, have you seen this in some hospice patients? And some patients with latent disease state? We can also see the same thing in family members. And the reason that I bring this up, is if we have a warrior patient and we have a warrior family member, then that's going to look different than when I give you some of these other examples. The next patient and family is the pacifist. And so the pacifist, they've lived a great life. They've lived many a years. They have fond memories. They're ready for the next thing, whatever that may look like. They're comfortable in de-escalating their medicines. They're comfortable in getting that MOLST. They tend to have pretty strong views about, I don't ever want to have to go back to the emergency department. I don't ever want to be in an ambulance again. And so that pacifist. And if you think about the family, the family could also be in this same kind of viewpoint. They're supportive of their loved one, and they're going to do whatever the loved one wants to do. And so that passive family member and that warrior patient, now here comes a conflict. And so the warrior patient can say, no, I want everything. And the family member says, no, hospice might be the better way to go. And you shouldn't need all that. And taking all those multivitamins and other things. And at the core of what this whole problem is, even for when you're working with patients and families, at the very crux of the whole thing, it's all about the loss of control. And being forced to do something different when for the last umpteen years you've been moving along, doing things in life in a certain way. So we have the warrior patient and family. We have the pacifist patient and family. We have one more to talk about. We have the diplomat. And so the diplomat wants to be very a la carte. And the diplomat is probably the patient that you will come across more often. They may be on hospice and they may say, I want certain things, or I might want to avail myself of the support in the emergency department. I want to keep certain medicines, but not others. I may want to be on hospice in a full code. And so the diplomat is going to be very a la carte in what you're looking for. And so again, if we think about the patient perspective of warrior, pacifist, and diplomat, and if we think about the family's perspective, warrior, pacifist, and diplomat, when they're aligned well, things go well. Now, one more thing to throw into this. We too are going to have, and even though we may not have a large prior history with a patient or family, we're going to have a perspective. And that perspective may be warrior, pacifist, or diplomat. We come to that conclusion, honed on many past experiences that we have with other patients and families. And so we may come to this thinking, you're really late in your disease course. There's no way that you should be taking all those medicines. There's no way that you should be utilizing healthcare services in the emergency department. This is not good for you. But this is what the patient wants, and now the family is a pacifist to this, and they want to be able to support the patient. So I found this to be a pretty useful tool in trying to kind of size things up. Medications, as far as kind of hardcore diagnostics of something to go to that's tangible. When you see someone who's late in disease course and they have 30 medicines, that's not your pacifist. That might be your diplomat, that might be your warrior. When family members come to meet you outside, you ever have that happen? And kind of explain things. And so you could see variations in both the diplomat, the pacifist, and the warrior for that as well. What do you think? Any questions about kind of the three ways of looking at families and patients? So I'd mentioned early on in the late 80s about the hospice benefit. And since that time, one of the bigger pieces of legislation that's gone through is the SelfDetermination Act. And what this allows for is for patients and even healthcare providers to say, I don't want that surgery, or I don't want to eat, or tube feeds, or I don't want IV fluid. And so it gives them the autonomy to be able to make those decisions. And then, there's been, several big court cases about patients who on hospice and not wanting to have aggressive therapy done, and some conflict and strife with family with this as well, and it's even made it up to the Supreme Court. You ever been thanked by a patient or family? What are they thanking you for? What's that? Okay.
how they treated the patient,
Okay.
their compassion.
Compassion. What else? You ever thank you for the lights and sirens? Yeah, probably not. Ever thank you for that dose of morphine? Maybe, right? But for me, one of the most eye-opening things that I experienced very late in my career is, I have letters of gratitude, and I'm sure you guys have letters of gratitude, and I've gotten cards and had some patients even visit, and, some really cool stories. And, he was so wonderful, and he took great care, but I never really kind of understood what I was being thanked for. I just figured it was my skill. I got lucky with the IV, or we moved quick enough, or everything just flowed really well. And it wasn't to this experience that I ended up having, and someone actually explained it to me. And it's not about the IV, it's not about the medicine, it's not about the ambulance, it's not about the fire truck. What they were actually thankful for and appreciative of is that connection. And that's where this population, when we want to try to be able to work with that, it's about making a connection. And so, which is kind of counterintuitive to, our goal is to get to the house, right? Get the patient assessed as quickly as we can, get the patient onto the cot as quick as we can, get the patient transported and turn things over, because chances are there's going to be another run to do in the very near future here. So, this is a quote from one of our colleagues that I heard said, did anyone tell this guy he was on hospice? What do you think about that one? Yeah, it's kind of a challenging thing to hear, and out of context, but both nationally as well as what my experience has been is about 20% of patients that are on hospice are going to access 911. And they're going to do so for a variety of reasons. Part of that is not fully realizing what the hospice thing is, despite the fact that there's a lot of education that happens. There's a lot of literature that's provided to them. There's a lot of revalidation saying, unless your house is burning down, we should be your first phone call. I think part of that is for the last 80 years, when I've had a problem, what do? I pick up and I call 911. And so it's just that kind of reaction that happens. There may be a lack of clarity about disease and prognosis. And so, we can tell somebody who's coming on the hospice that, you'll have 6 months to live, but how accepting is that person? Here's an interesting factoid. If you have a patient or family member and you provide that person with a bit of information that they're afraid of or don't agree with, how many times do you have to have that skillful conversation with them for that reality to start settling in? How many times do you have to have that discussion about de-escalating a MOLST or de-escalating medications? How many times do you think? 5 to 10 of these powerful conversations. And so the timing for this is critical. So it's not just a provider that maybe it's their primary care doc that's going to have these 5 or 10. That's going to be a variety of people that they're getting this information from. A large part of that information actually comes from you as well. That information may come from family members, may come from other healthcare providers, but any patient that comes on the service, one of the things that I see pretty much 100% of the time is they're always looking for some information that's going to support something other than what was previously said. A bit of denial, and that's healthy. There may be a desire to continue receiving care for non-hospice related things. There's also a lot of guilt that patients have about the burden that they place on their care providers. It could be very distressing and scary when it's time to manage symptoms. And if you've ever experienced shortness of breath or watched someone experience shortness of breath, seconds feel like minutes, minutes feel like hours, hours feel like days, and days feel like weeks for that experience. There's also, 911 is faster than the hospice nurse to get there. There is an element of that, and so we tend to, 80 to 90% of our time we get to our patients within an hour window. And then, families also have difficulty accepting what's going on. Now, when we look at the benefit of what it is that we do, going to the hospital is not without risk. We could give the wrong medicine, we could have an accident, there could be the wrong diagnosis, and the burden of care doesn't come without some limitations and challenges. Yes, sir.
I have a question. I've heard people in the past that if they call 911 and go to the hospital, they're going to be kicked out of hospice.
So let's talk about that one then. So I'm sorry, the question is that when patients call 911 to the emergency department, they're going to be kicked out of hospice. Patients that come on to hospice, probably 80% of them have just traditional Medicare. The other 20% of them have other insurance. And maybe they're carrying that insurance, or maybe it's from work, or and so that insurance also has an impact to that. Patients who call 911 and get transported to the ED, what ends up happening is a nurse goes out to the emergency department in pretty quick time. We meet with family, we meet with patients, we meet with nurses, we meet with the docs, and we come up with what that plan of care is. If the plan of care is reasonable and compatible to what the patient's diagnosis or hospice symptoms are that we're managing, they may stay on service with us. They may be admitted to the hospital. They may be admitted in observation status. They could be even admitted to a floor. Now, if they get admitted to the ICU, that becomes a bit of a challenge. Patients who have these secondary insurances may have extra carve-outs in their hospice benefit, and so it may allow for that patient to get it managed in an ICU or on a telemetry floor, or even have some surgery or for other things. And so it's a really challenging thing to be able to answer that. It actually requires the nurse at the bedside, the team physician to be involved, and then if somebody does have any secondary insurances, it requires a biller to also be involved to figure that out. When we get to the off hours, we try to delay that decision. And so let's say Friday night at 11 o'clock you go to the hospital, the nurse gets there by 1 o'clock, and there's a plan of care that's unclear of which direction this may go. We'll keep the patient on hospice, because what ends up happening for that patient that goes to the hospital is the payer is now the hospice and not the patient. And so here's kind of one of the benefits to hospice care is, under the Medicare benefit, it's the hospice that's now the payer as opposed to the patient for those things that are part of a plan of care, and for those things that are compatible with either the hospice diagnosis or the symptoms that we're trying to manage. Any other questions? There's a lot of studies out there that are supportive of the psychosocial support. I mean, if you think about it, if you're not feeling well, your family's stressed, you see a nurse a couple times, a hospice aide, a chaplain, a social worker, some volunteers, I mean, you could have 8 people coming to see you in a week. That contact that happens, that's one of the magic things that help support this reframing that happens for patients and families ultimately. And then there's a ton of studies that are out there that say that hospice benefits patients, and it's all about quality and symptom management. As we talk about our ED patients, some of the things that pop up for us to kind of get an understanding of is what is the benefit for them. And again, if you have 3 patients, the hospice benefit can look 3 different ways. Their DNR status, and so we have patients that are on hospice, and I think it's roughly 10% right now for us that they're full codes. Number of medicines is, again, kind of a very discrete way of getting a sense for where the patient is in this hospice journey. And then we talked about the interventions of being able to be thoughtful about how we're going to interact with a warrior patient and a diplomat family, or vice versa. When 911 is called, and probably in the most ideal kind of sense, is to be able to take the mindset of being able to partner up with patient and family. Because one of the things that just kind of naturally happens is anybody who's receiving health care tends to have a perspective that there's a gatekeeper we have to get through. And so being able to kind of partner up with them and get a sense for where they are. And so, this is, the kind of the better approach and the ideal way of doing this. This is that stay and play kind of situation as opposed to that load and go that we are kind of more commonly doing. There's a lot of education that happens by EMS for patients and families. And, but the biggest strategy, I think, that we do very differently than other healthcare settings do is it all about increasing the autonomy of patient and family. And so everything that we can to make sure that they're making their decisions and that they have their say and that this looks like what they want it to look like. Now the challenge is that's going to change potentially every day. And hospice is not a linear thing. It's sloppy, it's messy. And there tends to be a lot of extra work that's going to happen with patients and families as we're going through that. One of the interventions that we will try to do is patients that do go to the emergency department, can we improve their situation by getting them back to our inpatient unit? And so many patients will bring back and admit to one of our facilities, or do they need more resources at home? And so we increase nursing visits, we increase hospice aides, social workers, chaplains. Something that doesn't happen too often, and there's some impediments to this, but I think this is kind of the best case scenario, is when patients do call 911, reaching out to the hospice would probably be really, hopefully, beneficial. But the challenge is if anyone ever called a hospice, just out of curiosity? So there's a big phone tree to get through. There's a couple other patients that are waiting in line. And so, there's these impediments that do happen for that, but this may help in your plan of care or may help in supporting not transporting this patient. It is not uncommon for patient and family not to say anything and call 911 to us. And then what ends up happening is the CRISP alert will come through. So all patients that are on hospice are entered into the CRISP system. And so that flashes up. And once that flashes up, there's a nurse that gets sent out to the emergency department and tracks down and see what's going on. Yes, sir.
Can you provide some examples around the idea of being prepared to stay and play, partner up, meet them where they are? What is that?
So what does that look like? I have a perfect story for you on this one. So I had a patient a couple months ago in Cockeysville area. The patient had suffered a stroke the day before. I don't remember what the hospice diagnosis, but the patient was fairly well. I mean, he was alert, he was oriented, he was eating, he was sitting up by himself. And over the night, woke up, had a big change in mental status. And the daughter reached out to both us and 911. Just by dumb happenstance, we got there at the same time. The colleagues that I had the privilege of working with, and I think they were from 17, worked really well with a family member, being able to help her come to a decision. What is it that she's looking for? Because she didn't really know. And so they were able to articulate, this is what this looks like. And getting into a back of an ambulance, her father had been transported several times, but she had never been in an ambulance. And with the risk and the benefit of going to the emergency department, if he does go to the emergency department, we're going to have to bypass the other hospitals that are closer that she was looking for because the patient was having an active stroke. And so the destination of choice at that time was going to end up being in Sinai as opposed to, I think GBMC was available. And so there was a lot of education. I think what ended up happening is, we spent about 45 minutes there. And she became very comfortable with the fact that if something went wrong, she could then reach out again to us. She could also reach out to 911 if she wanted to. With that, we were able to get him back in the bed. We were able to get him comfortable managing his symptoms. Now, the one thing that ended up falling through on this one, to be transparent, is later on that day, his symptoms did extend. Family member did become really uncomfortable with what was happening. She did try to call me first, and unfortunately I wasn't able to pick up quick enough. I got the gist that she had frustrations waiting on the phone for us and called 911, and he ended up being transported later on that day. But I think the big thing is validating for the care provider that this is difficult, and helping with some strategies for doing some of the care. And so part of the discussion was the patient needs to be positioned comfortably in bed, that the patient needs to be sitting up more, helping to kind of reframe, this is expected, this is common, this is normal. This is no surprise that we're seeing this. However, when you're the loved one watching that patient go through that's a different story. So we talked about the Chesapeake Regional Information System, CRISP alerts, and all hospice patients are entered into that. And so the thing that I will always try to do for patients and families is at the very core of this I'd mentioned, there's always a conflict about control. And the loss of that control is a really big deal. And so one strategy for this is to never say no. And so the approach is to give choices. And my first approach is I always put out there, we do nothing. And then from there, hopefully I'm able to come up with a couple other choices and help patients and families with that. Patients, as we talked about, they may in fact be covered by insurance and some other things. And then with that, I think one of the things that is important for us to acknowledge is that when patients do revoke or do get discharged, and so patients will be discharged for pretty much only two things. The most common thing is they're out of our service area. And so if a patient goes to St. Agnes, we no longer have access to that patient, so they're out of our service area. Or if the patient moves from Baltimore County to Pennsylvania, they're no longer in our service area. Now the revocation that I mentioned before, patient or family can say, I want to go back to my other benefits for Medicare, in which case all the services stop, all the medicine stops, all the care providers stop. We then have to somehow quickly come up with a game plan to get you reconnected with whoever was providing your health care beforehand, and your Medicare services turn back on. Now the thing that's super important, as you mentioned earlier, you'll get discharged from hospice, is Medicare is rather smart about this. And so if you go seeking services that are incompatible with the plan of care of hospice, there's something that can happen and you can get stuck with a bill. So if Medicare is presented with a bill that's $784 for a day, or if they present it for an ED visit and that totals $20,000, which one do you think they're going to pay? $800 as opposed to $20,000. And so, for the education that we do for patients and families, it's really important to acknowledge that you may not be covered by Medicare for this, in which case you end up getting a bill. And so the smartest thing to do is to have them revocate. It switches back to what their original insurance was. And the beauty about this is tomorrow they can think, oh, this was totally the wrong idea. This is not what I wanted to do. We bring it back on service. Now, the downside to that is we bring it back on service, so which means the admissions nurse comes out, and that's a couple-hour visit, and then we have to get the equipment back into the home, and we have to get the medicines back into the home. And so it essentially mirrors another repeat of their admission. And so that can be disturbing for patients and families at times. But they can come back anytime they want. As a matter of fact, there was a guy and family I was working with, and Anne Arundel County ended up going to Baltimore Washington Medical Center, and in a matter of 3 months, he revoked 7 times. And that was going to be his pathway for this, and that's what his hospice journey was going to look like. And that's what it looks like. Again, this hospice thing, it's not linear. It's sloppy, it's messy, and at times doesn't always make sense or follow any good rules. So I want to shift gears again and talk about some of the things that we work with patients. There's a lot of stuff on the news, and in fact, I would say that all of us in here are kind of biased about the use of opioids. How many of us have seen someone who's OD'd on opioids in the last week? Give me a show of hands. Yeah? Who's pushed Narcan in the last month? Yeah? Quite a few. And so, patients that are on service with us at times can be on these super extraordinary doses of medications. Patients for end of life, depending on what systems are involved. The pain itself, what's kind of helpful for us is pain is an antagonist. And so with that, there's also a tolerance that's built. One of the things that always kind of comes out in discussion is, whoever pushed the last dose and the last breath. It gets to be a pretty distressing thing for families. And the doctrine of double effect is the ethical principle that we kind of apply to this. The thing about the doctrine of double effect is that if we're using medications in a skillful way, in a judicious manner that meets the standard of care, this doesn't really support that concept. One of the other things that comes off is, morphine is the drug that euthanizes patients, and we hear this a lot. The data, though, with 30 years of study to this, there's no scientific proof that morphine actually accelerates death. And you think, how could that be? Well, if we kind of think about what somebody at end of life looks like, and probably a better analogy to use is someone who is at end of life looks like shock. So you have an elevated heart rate. Their blood pressure may be compensating or in the short term or maybe changing. And so we think about it, this looks like shock. Now, if your body has a huge amount of stress on it and your heart rate's ticking away at 130 beats per minute, he who has the fastest heartbeat gets to the end faster. And so if we're able to kind of modulate some of that discomfort and slow down the heart rate by easing up pain and anxiety, that's going to look very different. In addition to that, when we look at respiratory depression with hospice patients, we don't really see that as well. And a big piece of that is typically our patients, when they're on hospice with us, they've had pain for an extended period of time. They have tolerance that's already there, and that tends to offset this. Now, if you look at the studies about respiratory depression and opioids, it was done with drug addicts, and so God only knows what you buy off the street. It was done with patients who were post-operatively who had pain. It was done with a bunch of folks who had volunteered to receive the medicine, and it was done with IV dosing. And so even in the inpatient center, IV dosing is the last form that we want to use for this. Preferentially, we want to be able to administer medicines orally, and I want to talk a little bit more about that. Or we may even administer medicines subcutaneously as well. And then what's really becoming new for us, and it's working really well, and quite honestly, I wish I would have had this in an ambulance many years ago, but the administration of medications rectally. And so there's a specialized tube now that in a matter of literally 15 seconds you can put into a patient, administer the medicines, and actually see an effect from the medicines that's almost as fast as IV, probably faster in IM, and certainly faster than PO. The studies looking at the administration of morphine and other opioids, both for respiratory depression, it doesn't support that we actually hasten people's death, that we actually impact their respiratory drive in such a way. If we think about that patient again, who now essentially is in shock, and as a result of shock, cells are dying. As a result of the dying of the cells, we have an acidosis that builds up. And so someone who's acidotic, what's it look like? Well, their respiratory rate is going to increase, and they're going to attempt to blow off that CO2 to try to equalize things out. And so you really just don't see respiratory depression from the medicines that we're using, even in patients that have these super extraordinarily high doses. Now, where you do see some problems with opioids, those that are opioid naive, and so we do have a smaller set of patients who their first experience to opioids in a chronic administration is with us. You may potentially see it with starting a new dose. And so if we were on 5 milligrams every 2 hours and we switched to 10 milligrams every 1 hour, maybe that might have an impact. Sometimes you see it when you change routes. And so we've been administering medications by PO, and now we change to IV. They're at a bit of a higher risk. And then sometimes even changing medicines. And so if we go to morphine to Dilaudid. But we're able to kind of account for those things with a little bit of creative math. The most common medicine that you're going to see being utilized is morphine. And what we're utilizing in the home and in facilities as well is the oral concentrate. And so it's 20 milligrams per milliliter. So 0.25 is 5, a half a cc is 10, and so forth. And the way that this medicine works is that it's prepared to be absorbed in the mouth. So roughly about 25% of that gets absorbed fairly quickly in the mouth. We're not always entirely clear what happens to the rest of it. And if you have patients who are receiving this and they're having problems with getting adequate pain relief, the first go-to thing to be thinking about is the family doing it right? And so if the patient has, if they're pocketing food, if they have a ton of secretions, if they're swallowing it immediately, they may lose part of the benefit of that dose. And for the dose to be of real benefit, the instructions that we do for family is to make sure that we do mouth care. And so there's spongy little swab things. In addition to that, the longer that the patient can play with it in their mouth or keep it in their mouth, the better the benefit. Now, as far as pain assessment, you ever have a situation to where you get there and the family says, yes, our loved one is having the worst case of pain in their entire life and they're sleeping. And then you wake them up and the person says, I'm having the worst pain of my entire life. And so at times, what's stated to us doesn't always marry well with what we clinically see. And that too is diagnostic. That's helpful information to know. Another challenge that we have for patients, especially in the older generation, which is a bit of stoicism. And so, they may want to deny the pain. They don't want to upset the patient or family, or they may even see it as weakness. Or it just might be something that's culturally more appropriate to deny discomfort than to admit to having a weakness. A telltale sign that's really there, no matter who you are experiencing pain in the biggest context of what this definition of pain is. So that could look like respiratory distress, that could look like emotional pain, or that could look like physiologic pain. It's a furrowing of the brow. And so look to the furrowing of the brow as a really good sign of a pain assessment. And where this really becomes important, let's think about the population that we can't ask, what is your pain? How about our dementia patients? How many dementia patients do we routinely see? And so, we see changes in behavior. We see the furrowing of the brow. We see them, maybe they were previously kind of active and now they don't want to move, or when they do move, they lash out. But they're not able to express to us, I'm having pain, or be able to give us that scale of 1 to 5. Dementia patients, anytime you see changes in behavior, anytime anything changes in a dementia patient from the chin down to the knees, start thinking about pain, constipation, urinary retention, and then infections. Most 2 common infections would be what? UTI and respiratory, right? And so it's not uncommon if you think about someone comes on hospice, they're now not eating as much as they normally would, they're now not having great fiber intake, they're now fairly immobile in bed, we're now giving them an opioid, we now are not giving them as much hydration as they would normally have, and the points here just kind of tick up for constipation. Constipation makes people do crazy things. I've heard of patients who were bedbound for long periods of time, who became constipated, decided to get up, and then they fall down, they hit their head, they get an epidural, or they break a hip. And so, we see this play out over and over again. Music. Music is a great intervention. Anyone use music in the back of the ambulance? For patients. Here's an interesting one for you guys. Where I first got turned on to this is we have music therapists at Gilchrist, and that's we can talk about that one for days, but super cool. But music, I did a literature search for music, and in a 10-year time span, there were over 5,000 articles about music. And what's fascinating, that when this was kind of introduced to me later in my career at Hopkins, and we would do long distance transports, sometimes a couple different states, we would ask them, what's your favorite song, what's your favorite thing to listen to, pull up Pandora on the phone. And I even have a Bluetooth speaker that I think I got as a gift or something like that, and sacrificed that. But I didn't have to fight with patients as much. I didn't have to argue with as much. I noticed that they were getting less medicine. And music therapy is really big. There's some huge studies for music therapy. I grabbed one that is a lower level study, but music therapy can reduce anxiety, pain, and depression, and shortness of breath, improve mood, and reduce a furrowed brow as well as vocalization. If you think about how this music thing works, part of pain that happens is also anxiety. And so if your pain level's here, and then your anxiety level's going up with it, it simply pushes up the pain. And so if you're able to distract them, and sometimes we do it with conversation, sometimes we do it with, hey, I see you're wearing a Raven shirt, or I see you are at the store, or where we come up with these creative conversations during the ride. But a great tool to use is music. I would challenge you to try to utilize that, and I would love to hear your feedback with that and see what you think. Some of the other symptoms. How many times have you been to pick up a patient, older patient, not even on hospice, that fell? One of the challenges with a patient that falls, once you fall once, you actually double your risk. How many times have you been to a facility and have you seen the beds that go all the way down to the ground? So if I'm older in age and I'm walking along and I trip and fall, my risk of injury is somewhere in the 20-ish, 30-ish% of having a substantial injury. If I'm in bed and I roll out of a normal bed, my risk of injury is in the high teens. If you put me into a low boy and the bed goes all the way down to the floor, my risk of injury is less than 10%. If you put me all the way down on the floor, as well as put a safety mat, a fall mat, and preferentially one that has the beveled edges so those that are caring for the patient don't trip over it and fall, you now reduce the risk to 1%. 1%. And so interventions that include bedside commodes, bed alarms, these things. The thing that's just absolutely important about falls in patients is that we shouldn't think that a fall is just a natural course, that everybody falls and that's just the way it's going to be. I think all of us as a public health kind of initiative, if we start looking for ways of preventing that, and so maybe it's a dog that's running loose, maybe it's cords going across a walking area, maybe it's throw rugs, but there are a whole variety of things to be looking at that you guys as well can reinforce with patients and families that this is not the best way of doing this. Atropine is a medication that we use quite a bit. We probably use it too much, to be honest. Death rattles, you guys heard this one before? And so patients with terminal secretions, and what it really amounts to is someone who just has a really loose, floppy airway, who basically is snoring and then has a collection of fluid in their throat. The way that you can differentiate terminal secretions from other respiratory pathology is auscultation typically doesn't help. Because if they have this collection up here, and literally you can hear them from across the room. The guys experience patients with terminal secretions you literally hear from across the room. Probably the easiest way to get a sense is this terminal secretions or not, is to feel for fremitus. So take your hand and simply lay it against your neck, and then take your hand and put it on their chest. If you feel lots here and not as much down below, then chances are it's probably terminal secretions. Now, the difficulty thing about terminal secretions is when we're giving atropine and other anticholinergic medicines, what are we treating? We're treating the patient? So the interesting thing is, I've never had one patient with terminal secretions that came back and said that was really disturbing to me. Not to be funny, but sometimes patients rally back and we ask them about, what do you remember about yesterday? Did you know you were snoring yesterday? Did you have any respiratory distress? And the answer is always no. And so the thing with terminal secretions, 9 times out of 10, their respiratory rate is going to be elevated, but is that respiratory distress, or is that because it's cosmal respirations and they're profoundly acidotic? Those that are acidotic and blowing off CO2, that's not respiratory distress. And so for families, however, it can be really distressing to hear that noise. The best intervention by far, and what's even better supported in the literature, is positioning first. And so you get the patient up 35, 45 degrees, and you get them far to one side or the other. You do some mouth care. There's even some hospices that are putting patients in reverse T-Berg and turning them, and then clearing out their mouth and putting them back up. But that's, I think it's a higher risk for aspiration. I don't think I'd be particularly comfortable in doing that. The thing about terminal secretions is trying to suction it, you're asking for problems. And if you think about, by the way, the largest organ in the body is skin, right? And so if the tissue is very friable in someone's arm, what's it going to be in the back of their throat? And so if we go chasing after that with a Yankauer, and we give them a little bit of a hickey, and that hickey then starts bleeding, and then we're going to have a really big mess. And so there tend not to be a lot of benefit by suctioning patients out. There tends to be a lot of risk in doing that. Positioning is definitely, I think, the best way to go. Now, alternatively, is we use atropine and some other anticholinergic agents. The atropine preparation that we use is actually an ophthalmic preparation, and we actually do a couple drops in their mouth. The problem, though, with the atropine is I'm pretty confident that if I asked you guys to demonstrate to me what a drop is, we're going to have good consistency. What I see from patients, family members, though, is big squirts. And so I've seen pretty substantial doses of atropine given to patients. And so atropine's problematic. It's a big cause for delirium. It can equate the falls. It can equate the constipation, urinary retention. And so it's not a medicine that we should take lightly, even though it comes in a little small bottle. Ativan is commonly used for patients, and we use it primarily for anxiety. And then we use it with the mindset that we want to provide sedation. Ativan is a better choice for patients with Parkinson's as opposed to Haldol. And so Haldol affects dopamine. And so Parkinson's patients have problems with dopamine. We want to stay away from Haldol with Parkinson's. And the downside with Haldol is there's black box warnings for it that it increases the risk of fall, and fall is a pretty big problem in the consideration. Haldol, however, is a better drug to be used for changing behavior. And so if we have a patient with dementia who's now lashing out, that might be a better selection than using Ativan. And in addition, if we're going to use Ativan, there's going to be a bigger sedating effect. And so that reduces quality time that the patient's going to have with their family member. PCA pumps, have you guys come across PCA pumps in the field? And so sometimes it's by IV. Rarely will you find a PCA pump IV peripherally. It tends to be through either a port or through a Medline or through a PIC or through a central line. We will also do PCA pumps subcutaneously. And so the subcutaneous administration, and they'll still get a rate that's around the clock every hour, and they can also be able to bolus themselves. But just to give you guys a heads up, if there's ever a PCA problem, there's always a backup PCA pump that's kept in the home. So there's always 2 pumps, and there's always supposed to be a backup medicine that's in the home. So if someone uses their last bit of medication, that's an urgency for us, and we get something shipped out the same day. So my colleagues at Hopkins came up with this graphic here. This graphic, they turned into a henna tattoo. And so if you're working with a palliative care group at Hopkins, and you're rotating with their service for that month, you get this henna tattoo, and it goes into the inside of your left arm. And did you ever go have a sit-down conversation with a patient or family, and you kind of had your thoughts in order, but you kind of waffled, and you're kind of struggling to think about what you're going to say next? And so when we're having these conversations with patients and families, what Dr. Tom's group ended up doing is you casually look down to your arm, and then you come up with that question. And what these questions are ways of being able to start the conversation. And you guys will walk in cold to patient and family, and these situations you're not going to have any past content to 99% of the time. And so being able to start the conversation is what this is used for. And the challenge with this is we shouldn't look at this as scripting. We should look at this as a tool. And for this, you got to make it your tool. You got to play with it. You probably have some one-liners that you use with patients and families now, and this is simply another example for that. Probably my number one go-to one-liner to use that I find incredibly helpful, by the way, it even works with my wife, please don't share that, is what's most important to you right now? And what's interesting when I say this, what's most important to you right now? Maybe the answer is I don't want to be in pain right now. And maybe the next time you see him is I want to be able to make it to my grandson's graduation. Or maybe the next answer might be I want to be able to walk to the bathroom by myself. What I have found when I ask this question, I now don't have to guess. It makes my work so much easier, and it helps support our connection and being able to develop consensus about what's going on and the information I'm trying to get and what's most important to them. But clearly, as you guys know, patients and families, they're in crisis. They don't follow rules. They don't listen well. And that's a big struggle for them. But strategy-wise for you guys is, and the thing that's just so incredibly important about patients that we work with probably across the board, is there are a couple things that just absolutely crush a therapeutic relationship. Probably the best one is this, right? Radios we need, but radios can do it, computers do it. And so anytime that we look like we're not actively engaged, anytime that we get there and it's like, oh, I know this guy, I've transported him 10 times, and you roll your eyes. Maybe number 10 here is something very different than the previous 9. And so being able to make that connection and foster that therapeutic relationship, because if not, then it becomes kind of adversarial. And then it potentially leads to somebody acting out or misbehaving or things getting missed and medical oversights happening. So, what does DNRB mean? Go ahead, be bold. Do not resuscitate. What else? Okay. The one description that I think is really problematic, and I heard this from a Baltimore City colleague, do nothing riding backwards. Yeah, and like in the wrong context of, we see stuff, we are exposed to things. And when that person is calling us, as you guys know full well, they're having the biggest crisis of their life. It's the worst day they've ever had. And, but we've already experienced 3 other runs for this just for today alone. But yeah, DNRB, do nothing riding backwards is definitely not the way to go. So some of the things that you can do with our patients, those that are basic life support type transfers for that DNRB, and they're having pain, maybe it's appropriate to rendezvous up with an ALS provider and they can provide some morphine. They may need specialty care transport, and I have one to show you what this looks like at the end of this presentation, but we have patients who are coming out of the ICU who are vented on pressors. We've had patients who have had left ventricular assist devices. We've had patients receiving pulmonary hypertension infusions, and so they might need specialty care to get them from point A to point B. Oxygen is a really good thing to utilize, and One of the interesting things about oxygen in hospice patients, again, looking at the research, the administration of oxygen to a patient who's end of life doesn't really demonstrate a clear effect. So if you have pneumonia and we give you oxygen, chances are you've had a pretty abrupt change physiologically, and your cells are going to say thank you for when we give that oxygen. But patients for end of life, they tend to get as much benefit from a small to medium-sized fan directed at their face. And think about your COPD patients when you go pick them up. Commonly you see a fan in their living environment. Not an overhead, not a real big one, but a small to medium-sized one. Much of the derived benefit from oxygen, many of my colleagues are thinking it's almost sort of like a CPAP kind of situation. So they have 6 liters going through the nasal cannula, and as a result of that, it's kind of fooling their body physiologically that they're getting more air. It's not so much the oxygen that benefits them. Suction can be done, but again, be very cautious about that. Yes, sir.
So do you think that's a bit of a placebo effect?
So I think that can be very much. So one of the
I think that sometimes.
yeah.
Give it to them. As long as they feel something blowing, they're happy.
Yeah.
Whether it's doing it, and their stat might not change.
Yeah, exactly. And it's not uncommon to see someone who, without respiratory distress and end of life, who's got an oxygenation in the 70s, and someone who is end of life and has a pulse ox in the 90s, and that pulse ox at 90, they still have respiratory distress. So there's these three phenomenons, one of which is halo. And so just by your presence of being here, that improves my well-being. Thorn effect. The thorn effect is, I've had bad experience with healthcare, and I know when I call 911, they're going to be mean to me, and I'm prepared for that. Or I have to wheel and deal to get to the hospital I want, and I perceive you as my gatekeeper. And then the placebo effect, and I think the placebo effect is a legit thing. I think it's helpful as well. I think we need to be clear about what it is that we're saying. So I'm not going to give you 10 cc's of saline and tell you that it's morphine. I'm going to come and provide these interventions. And so maybe part of that is the fact that I'm there, the halo effect. The other part is I get you positioned. I de-escalate your anxiety. I do these 10 other things for you that are really not ALS level kind of things. That's where the benefit, I think, in part comes from. Another good descriptor on this, and I would recommend giving this a try in a very controlled condition. The next time you're driving along, preferably as the passenger, roll down the window, close your eyes, and stick your face out, ideally with nothing else coming at you. And take a big deep breath in and see what that feels like. Has everyone here had a nasal cannula on? Has everyone tried a nasal cannula? And so, when you're breathing in with a nasal cannula and it's put in there appropriately, there is a little bit of a boost that you get with that. Music. I can't overstress the use of music. You will be surprised the feedback you get from those that you're working with. Distraction, you're probably doing, and active listening, again, it's really important. And making sure that that professional appearance can also impact this. And so, if we're taking somebody seriously about their discomfort, being able to engage with them in a way that they know that we're being therapeutic and not being discounting to that. Hot and cold packs, I think, are underutilized. TENS units are underutilized, and many patients have TENS units, and they didn't think about it. Then you'd be surprised what you can do with a TENS unit. Yes, sir. So a TENS unit provides electrical stimulation. You could have them, some that have 2 patches, some that have 4 patches. And the stimulation that's applied, you can increase the amplitude and you can change the waveform and how it's derived. And what it essentially does is, if you have pain in your arm here, and we put the patches along your nerve areas, and we apply this stimulus, we find that it kind of erases the pain response that you're getting and kind of distract them. Many people have it for like back discomfort, works really well, legs, arms. The next thing I want to talk about is MOLST. MOLST, my colleagues report the most amount of difficulty in working with EMS tends to be about MOLST. For patients on service, our first preference is that they put them on the refrigerator. Sometimes patients don't want them there. Our next preference is on the back of the front door. So when the door is closed, you clearly see the MOLST there. And then the third preference would be in the folder. All patients have folders, and it clearly denotes who the care providers are. It clearly denotes the emergency number that's there. But as you guys work with MOLST every day, probably one of the bigger conflict that happens is the use of that second page. And so at the very top of that second page, there's a bit of information that sits up there, and it says orders in sections 2 through 9 below do not apply to EMS. And so the intent of this page was not for our use. And at times I've seen, page 2, flip 2, and now the medic's trying to wheel and deal with the patient saying, well, it says here you don't want to be transported, and so you shouldn't be transported. And if you do get transported, they're not going to do anything for you. Well, which I've covered earlier, that quite a bit can be done. So be careful about this one. It's the intent of this part of the tool was to more so help facilities, and with that be able to share information when patients do go to the hospital to help with the care providers there. Yes, sir.
But on the other side of that, the patient can also revoke the MOLST.
Yeah. So and here's where we've had some challenges. We've had some interesting situations within the last couple months. Patients can orally revoke a MOLST themselves. One of the more challenging situations is when patients don't have capacity to be able to revoke. And let's say the family member is the one that set up the MOLST for them. And now there's a crisis that happens, and the family member wants to be able to orally revoke that, and they can't. When the MOLST was made, and so they can't do that. And so when that MOLST was originally made, the thought process being is that in the best of context and situation and resources and support and opportunity for discussion, that's when that conversation happened. And now what can happen, and what we saw not too long ago, is we had a family member who didn't share that there was a MOLST, and then took the MOLST and hid it. And so it was the wife that did this. The daughter, who, strangely enough, the father appointed the daughter as the healthcare decision maker. And 911 was called, they arrive, patient's in cardiac arrest. She's saying, do CPR, do CPR. I don't think she even shared that the patient was on hospice. And lo and behold, shortly thereafter, later, strictly by dumb luck, one of our nurses was going for a scheduled visit that was pre-negotiated. And the daughter also gets there, and so she sees CPR being in progress, there's a missing MOLST, and now things get really ugly. Patients have the right to decline having the discussion. Patients have the right to de-escalate their MOLST or not use their MOLST at all. But family members are kind of limited in this. And so, the easier context of this is it's not worth the fight. It's easier to transport the patient and provide a palliative strategies for care and get the patient to the emergency department and let more resources be able to deal with that. Have you guys come across pictures for MOLST? And so that's allowable under protocols for us. Paper copies are certainly legal. Non-Maryland documentation is also legal, but the only thing that has to be filled out for MOLST is that page 1. And so the pitfalls we kind of talked about, and, at times there's missing MOLST. Again, if someone can give us a call, it's a perfect thing to, if the family member needs something to do, have the family member give us a call, and so we can certainly text over a MOLST. And we will share that pretty easily. The challenge with our system that we use for documentation is we don't have the ability to print in people's homes. And so, at times I've had to share my computer screen and somebody takes a picture of that, and the utilization for a MOLST for that is generally accepted as being okay. as opposed to taking pictures of somebody's medical record is a little bit different. Yes, sir.
But you said earlier that if we were to call to get a copy of the MOLST, that's not often instantaneous. Is that correct?
We can get as fast as possible. I've seen it done successfully, so I've seen it emailed, I've seen it text.
If somebody answers the phone, is able to help us?
Yes, the triage folks are able to do that.
Is most available on CRISP?
Yes, and so patients that come on service to us, we're able to see if they're a DNR A, B.
It's not obvious.
It's not obvious where on CRISP it is.
Yeah, so I don't get to work with that too much, but my triage nurses do. And
Maybe I'll follow up.
yeah, I can certainly get some better information on that one. Any past situations with hospice, like why did they do that?
I had a patient recently who had a DNRB form. He was in a nursing home. I don't know if he was in hospice or not. 'Cause
Okay.
I didn't know that that was such a thing. But he'd had 3 strokes in the past and looked like he was having another stroke.
Okay.
And I got this piece of paper that says, don't start an IV, comfort care only. And I get to the hospital and they take him to the CT scanner and
Yeah.
the TPA.
Yeah, so that's
Repeat for the one I-
so the question was there was a patient with a DNRB who was in a skilled nursing center who looked like he was having a stroke. Patient was transported to a hospital and then was activated as a stroke patient. That's a challenge at times. I don't know, Dr. Barinholtz, you want to make comment to that one, or?
I've seen that.
Yeah, and it's going to happen, and
Gave him TPA.
yeah,
Yeah, I'm Sinai, it's a stroke center.
yeah.
They come in and then it's a problem, especially when you have family members saying opposite things.
Yeah, and so the guidance for MOLST for providers in a hospital setting, because there's many more resources, it's not uncommon practice for a MOLST not to be adhered to, especially with a family member that's really loud. And the strategy for this is we want to try to meet them where they are, and so making a contentious relationship by saying no. And so instead, they're doing some of this care in the hopes that, within the next hours or to a day, to be able to get good consensus now on what that looks like. But yeah, it's problematic, especially if that's not what you wanted as an individual. I think that practice is becoming less and less prevalent. And I do hear many more conversations about, the patient has an active DNR, you can't do that, or, what's the DNR status? And so I think it's happening, but if you see one, it simply rings out that you've seen many more. Yes, ma'am.
I'm not sure if you haven't gotten to it yet, but hospice without most DNR.
So any patient that comes to hospice has to have a MOLST. And so even if it says full code, they have to have a MOLST.
Okay, so then hospice without DNR. Are we,
So you can be a full code on hospice, and that's about 10% of our patients. But as far as the paperwork, if you're on service, you have to have the paperwork. Yes, sir.
It's sort of in that, I've been on several calls where it's a hospice patient,
Uh-huh.
but they call us to pronounce the patient.
So at facilities or at home, and so my guess is family. My apologies. And so the question was, I've seen situations to where we've had to pronounce people in their home that were on hospice, and my guess is that just a knee-jerk response from family. But patients that are on hospice and that do pass away, nurses get sent out, and that's pretty much standard throughout the industry. I've not seen anybody else doing anything different. At times where we do have some controversy is patients in skilled facilities. Sometimes the skilled facilities will allow nursing staff to be able to make the assessment of the absence of pulse and respiration and pupillary response. And other facilities do not. But in the home care setting, The hospice didn't call specifically for that. Yes, ma'am.
So I've had situations before where we've been called out for a hospice patient, for either they were a full code and we worked at priority 4,
Uh-huh.
or confirmation of death. And in that situation, I was told that police do not handle it, that the hospice nurse then
Yeah.
handles that.
So as soon as we,
Your question, please?
once again, if you could summarize again for me.
So called either for confirmation of death
Okay.
or termination or resuscitation happened, and then police responded but
Yep.
did not handle the situation.
Yeah, so for patients that are on service with hospice and you're dispatched out for resuscitation and then ultimately termination, the police will then hand that off most frequently to hospice. Then, if there's any question about, was there an accidental death or not, it's a responsibility for the hospice to be able to make an assessment on that. If there's anything criminal in nature, then, obviously police would be more involved, the medical examiner would be involved. But when patients are on service, the expectation is we are dispatched out. And if you've beaten me there and you've made the termination decision, and we get there afterwards, we'll take care of everything else that comes with it. Yes, ma'am.
I had a really unusual situation one time where the patient was on hospice and the hospice nurse was on scene, and the patient expired,
Yeah.
and they called us.
Patient did?
Somebody from the home called.
Probably
us,
patient or a family, I'm sorry.
But the hospice nurse was there.
Yeah,
And
so,
when we got there, the hospice nurse said that she had to call us because the patient had had a fall recently, but they wouldn't let us in the house because they said the family didn't want us to go into the house. It made no
That's-
sense to me at all. I didn't know what to do.
yeah, so the question was, there was a patient, and EMS was called for, and the hospice nurse was present, and the rationale for the call for 911, that the patient had expired, but there was also a fall. I'm not sure why that would have happened, because when this happens for us and we suspect an accidental death, we then make contact with the forensic examiners, who then make contact with the medical examiner that's on call and present patients, but it doesn't require EMS response for that.
Police were also on scene,
Huh.
so I don't know why.
Yeah, that's really weird. Now, I've had situations to where I'm working with a patient, and a family member called 911, and people show up behind me, and it's like, hey, what are you doing here? So it could be a situation to where someone called 911, family-wise, but it's not a requirement for that to happen. Yes, ma'am.
I have a question from online. It says, why do hospice patients who are not in pain still get PO morphine?
Morphine we utilize for respiratory distress as well. The benefit for morphine in that patient population is it provides some venodilation, and so reduces some of the work for respiratory distress. There are some hospices that will send comfort packs out. It's not something that we're doing. And so sometimes patient will come on service to a hospice, they'll get morphine, they'll get Ducalox, they'll get atropine, they'll get Ativan, and that's sent automatically there as a bridge, and to not delay getting medicines from a local pharmacy. Nursing staff does not carry any of the medicines, and so we have to get them from local pharmacies. Yes, sir.
Okay, so my question is, do you interview the spouse of an elderly person or their kids? Because family's been married, husband and wife for so long, they don't want to see them suffer. I got 30 milliliters of morphine now, I got 30 milliliters of diazepam, I have Haldol.
So,
But they could end the person.
yeah, so the question is with regard to maybe like what frequency and what risk does suicide.
And how do you,
And so, yeah, so when patients for us that come on service, there's a pretty significant assessment that goes into making a decision how the medicine's going to be used, what medicine we're going to provide. Some of the challenges about the medicine And it's just kind of logistics. Can the patient swallow? Can the patient not swallow? Does the patient have allergies? Has the patient had bad responses to the medicine before? And then kind of the discussion about how are we keeping the medicine, how safe we're going to be. And so there is a suicide assessment, and that's a big part of that is also the social worker that is also required to see the patient when they first come on service.
But it does happen.
It does happen, yep. Yeah, it's actually, the regulations that we follow, they're referred to as COPS, C-O-P-S. It's conditions of participation. And so it's one of those things that we have to assess for.
And has anyone ever been charged with murder?
We've had 2 in the last 5 years that there was a full-blown investigation. I didn't hear or see anything afterwards that came of it. But both patients, there were detectives involved and medical examiner involved. Yes, sir.
Are you seeing any medical marijuana?
Oh, we're seeing lots of medical marijuana. Medical marijuana is kind of a challenge to work with. One of the barriers of getting it, first of all, is at times problematic for folks. There is still a general reluctance for healthcare providers to want to prescribe. There's this federal regulation thing that kind of frowns on that, despite what the state level does. And then, being able to get the quality controls for medicines is not on par with the quality controls for medical marijuana. And so you have to be able to figure out the amount of CBD and THC ratios, and then if you get one product from one distributor and they end up getting that from elsewhere, it may not be that same ratio or percentage and content. And so it's a very trial and error. We tend to be pretty tolerant about it, basically working with it. More is if you see benefit and it works, fine. If you don't see benefit, then you gave it a try. My past experiences, I think for the most part, at the very least, again, we're back to the placebo effect. Worst case scenario, they tried it, wasn't palatable, didn't want to do it, and so they stop. Yes, sir.
So could you just clarify again? So a MOLST completed by a family member for a patient without capacity.
Correct.
You show up.
Correct.
The patient may obviously not have capacity, and or the family shares that I have decision making. I have
Yep.
decision maker. I'm rescinding that MOLST.
Yeah, and so in that context, and it's the classic thing that happens is, let's say the patient had dementia, and family sat down with providers, a MOLST was made, it's a DNRB, and as the patient goes through their hospice journey, some crisis happens, 911's called, and now the family member wants to be able to say, I want to revoke the MOLST, and unfortunately, from a legal standpoint, that's not supported. And the best strategy is to try to meet them where they are, certainly transport the patient, and when you get them to the ED, it may be the scenario of that stroke patient getting TPA again, but the more amount of resources, that's where that battle is better to be had, as opposed to you guys having to deal with that.
And the Maryland protocol allows a physician, a nurse practitioner, or a physician assistant.
Now PAs.
On site.
On site, physically on site.
MOLST.
Correct.
But not by phone.
Correct. And
Can you just repeat that?
yeah, clarification that physicians, nurse practitioners, and PAs on site may be able to revoke a MOLST. And so they're taking responsibility for that patient, but they have to be physically on site. That's not something that they can do by phone.
I had a situation one time where a mom had a DNR, but she was in a nursing home and the DNR was not available in her apartment.
Okay.
And the daughter showed up on scene and said, do not resuscitate her, she's a DNRB, and the daughter is a physician.
Yeah, that's a rough situation. We just had this, and it escalated into something really ugly. And unfortunately, it is what it is.
So even as a physician on scene?
So as a physician on scene, do not resuscitate. Yeah, it's her mother. Yeah, and I guess you would have to be able to somehow clearly say that she's a physician. Does she show up in a pair of scrubs and an ID saying
She had a license.
had a license in hand? Yeah, and so a physician on scene, that's kind of a different bag of worms there.
It doesn't matter that she's her daughter or not. She can still say.
Ethically, I don't know. What are your thoughts there?
Say it one more time. We were having a private estate side discussion.
A patient has a DNR, but
Right.
it's not immediately available in the place where she lives, but her
Right.
daughter comes on scene and says, do
Right.
not stop CPR, do not resuscitate, and she's a doctor, and she has a
There's
license.
a problem there. It's like, you're a physician, but you have a direct relation here. It's like, you don't prescribe narcotics for yourself or your family members either. Or it kind of frowns on that.
Actually, sir, if we can get you to repeat that one with the microphone.
Family members, you're not supposed to, if you're a physician, is that right? Okay. You don't prescribe narcotics for yourself or your spouse or your kid. The Board of Physicians kind of frowns on that. And here, there's too many questions. Is there secondary gains? Is there not? You don't make a decision like that as a doctor. Your input as a child, yes, but as the physician, it's kind of a conflict. It's a bad scenario no matter what.
Yeah. I think at that point, I definitely want to be on the line with whoever the medical director on call is.
Your medical director on call. So, I think that the protocol, I welcome EMS leadership and their thought on this because I think it does come up. I think it's going to be very difficult for our providers to make that distinction. I think that the protocol clearly says if you have a physician, a nurse practitioner, or a PA on scene, they can revoke a MOLST. I think it's going to be very challenging for our providers, if not questionable, to be able to untangle this issue. Oh, well, you're related, or you're not the care physician, you're a physician, you're not that patient.
Yeah.
I don't agree with Dr. Sagal. I don't know what the right answer is, but I'll go on record and just say I think the state protocol is clear. I don't know if our EMS leadership has other guidance on that, but this does come up, so I really would like to clarify it.
You're absolutely correct. It's unethical. I would not do it. If you have any doubts, contact medical control.
You would not do what? Stop resuscitating?
No, I would not listen to your daughter.
Oh, okay.
She's too connected to the situation.
Okay.
And you don't sign a MOLST form in a split second.
Yeah.
It's an educated decision.
I think the problem was that the nursing home didn't have the MOLST available in her apartment.
So, Captain, if we can get you to repeat again with the mic.
Yeah, so Captain Nett said that she absolutely would not honor that physician's request to rescind that MOLST if that was the patient's daughter. Is that
Yeah,
correct?
I would
Captain
definitely
Nett?
want online help for that one.
Yeah. That's always available as a backup, is you can always get on the radio and go through EMRC to talk to a medical.
With the mic again for us, sir, so we can help those online.
You can always get online through EMRC and talk to a medical resource center, such as one of the ER physicians, to get their unbiased outside view. They're always available. And the other nice thing about it, it's recorded.
Yeah.
But this physician didn't want to revoke the MOLST. She said, she has a MOLST, and I want you to honor the MOLST.
If she has the MOLST and she shows it to you,
She didn't have a paper.
well,
Yeah.
that's a slight problem there now, isn't it?
Yeah.
Answer's still the same.
The answer's still the same. Don?
Stop
I think it's very
resuscitation or not
simple.
stop.
I think it's very
I
simple.
would do what I would do without the MOLST there because you don't know if it exists or not.
Can you repeat that again,
Take
please?
her word for it.
Okay.
I think it's very simple. We just.
Hold on, Donald, please.
So the answer is you would continue with the resuscitation because you don't know whether the MOLST exists or not. You don't know what an ulterior motive she may have. And the fact that she is connected to the patient, that it's just ethically incorrect.
And so my past experience with something similar to this is my medical director, my protocols, I have to follow that. Let me get on the phone while we do this. And
Right, so two very different situations, right? One in which you're saying the daughter is a physician and wants to rescind the MOLST.
Right.
That's a separate discussion than what they're talking about now, where Beth, you brought up that a patient's daughter shows up and says, wait, they have a MOLST, but we don't have a copy of it with us. Captain Natz is saying, absolutely resuscitate.
I think my question is, hopefully it's very simple to us that maybe it's approach to stay with the protocol that it can't be a physician. It has to be, or a PA or nurse practitioner. It has to be the patients. No, it has to be the patients. That's what I'm saying. Maybe we need to approach to stay with the state to be more specific when that has to be someone has to do with the patient's care. It can't be just any patient. We don't stop on a scene on the side of the road and somebody says, I'm a doctor.
Yeah.
If you're going to do that, that's a very scary slope. So it has to be the patients.
And my last couple of doctors, respectfully, are dermatologists, and it gets to be a little bit challenging.
But is it the patient's dermatologist?
The patient's podiatrist. Is there any more comments on that? No, let's go.
So last slide for you guys, just a few minutes here. I want to show you a video that I was able to get produced. It was Jack Dundee was a patient that was at Hopkins. He had been there for 8 or 9 months. He spent the overwhelming majority amount of time in the ICU, and in halfway through his course, he just wasn't what he wanted. And for family, he stuck it out and did the best that he possibly could. But finally, there was consensus for him and family that he just wanted to get home. His only thing was he wanted to get home. He wanted to get to his back porch to watch a sunset, and he wanted to drink an old fashioned. And so there was a lot of planning that went into this. Now, after the transport, we'd had some conversations with family, and we were looking for ways to try to improve access for patients to get home, especially those sitting in an ICU with who are intubated, who are on pressors, who are getting all these other modalities, and their goal is to get home. So this is the video for that.
My father was the picture of health, a 70-year-old man with no issues, the kind of guy who never needed the doctor, took care of himself, ate well, exercised, and then he had a heart attack.
Here at Johns Hopkins Lifeline Transport, when a family member or a patient is at their worst moment, we go there and try to make them at ease as best we can.
The Lifeline teams got to know Mr. Dundee. They knew him as Mr. Jack because his condition required him to be here for an extended time. They transported him a number of times for a variety of tests and studies and procedures. And so they came to know him pretty well.
He had made his decision that he was ready for the end of life, and that going on the way things were any longer didn't make any sense.
If this is what he wants us to continue to fight, then we're willing to continue to do that with all of you, but we want to make you aware there are options available. And if we can try to get you home, we will get you home.
We're so used to trying to prolong or correct issues with someone, and it's a difficult mindset to embrace for us to try and accept something like hospice, to take someone home that they've reached a point in their life or their hospitalization where they don't have any quality of life.
Our Lifeline teams use sophisticated equipment, administer medications, and monitor patients every day. It's what they do. It's just that this time, instead of rushing somebody to the hospital, they were bringing somebody home to see a last sunset and to be with his family.
And so once he came to that conclusion, he came to it very quickly and wanted to come home the very next day. The nurses and doctors on the floor connected with Lifeline to start to talk about how to make this happen. We also believe that he picked the very next day, the 21st of June, because it was also his birthday. So when you choose to die on your birthday, you have a day that's happy and it's sad for your family who misses you.
It was very different in that we got to know him and some of his family over his time, but it seemed like this was truly important for him.
You think about someone knowing, I'm going to die today, and that seems nothing but heavy and bad.
Knowing him and knowing this is something he truly wanted, things like to see his family, to have Christmas, to see one final sunset, even have one last old-fashioned, which he snuck in on us. It's something that truly meant a lot to him and his family.
We should be allowed to die the way we want to if we're afforded that choice, with dignity, with compassion, doing it the way we want to do it.
I actually reflect back on that day as happy. Happy for him, happy for us. It was not what I expected, but in a fantastic way.
So Mr. Jack served in the military. He worked on submarines. It did some pretty impressive stuff throughout his career. The other backstory to this is getting him there was a real challenge. There was a threat of a tornado, hail, a car accident. They got him there just in the right amount of time. They were met with roughly 50 or so people. They celebrated birthday, they celebrated Christmas, they opened gifts, they had loud music. The team ended up staying with him for about 12 hours. Then they ended up withdrawing care and made sure that he was comfortable. And he passed within an hour or two after that. So I think this is the best version of what this could look like. Guys, thank you all for your time and attention.